Great, welcome, and thanks for coming. This is kind of a huge topic, so hopefully this won't be too much of a whirlwind, but what we're going to try to do is go through important topics for women to think about at all stages of their health. And some of this might apply to you personally or to your daughters or sisters or mothers, regardless of what age all those different people are. So as Christina said, I'm from Connecticut. I went to Boston College, met my husband up there. We both went down to University of Florida for my medical school and his PhD. Then we went up to Long Island, which is what you can see here. I did my residency there. We took a trip around the world. We worked in Cameroon in a hospital in West Africa for about 2 months, and then went around the world the rest of the way on the way back. Came back to New York, and I was an attending up there for 4 years. And then in 2008, we had this little one, and we moved to Kentucky. So that's coming up on 6 years ago. But what I've learned since I've lived here is that in Louisville reckoning, that still makes me a newcomer. But I'm happy to be here. We love this city, and I think this is a great organization that we're all part of here. So how about you guys? How about a raise of hands? Who is involved in clinical care here? So a couple of people, and then other people, other support for our organization, but not direct patient care. Yeah. Okay. Excellent. Very good. Thank you all for your efforts. One thing that draws a lot of people to OBGYN is the excitement of delivering babies, and I do love that part of my job. Another part of what I really love is the diversity of the different kinds of women that I get to take care of, and the different kinds of issues that are important to women at different parts of their life cycle. That makes my day really exciting, and whether I'm learning about, I don't know, what kind of background it takes to become an FBI agent or a mortuary scientist, or what the schools are like in Oldham County, or where you can learn how to ride horseback around here. I love meeting women at different points of their life and hearing some of their stories. That's a big part of what's exciting to me. In terms of how to be healthy, it's important to know your enemy. So when we think about health, you can flip it upside down and say, well, what kills women? And this slide is from the CDC's mortality data. So this is #1 killers of women in terms of % of deaths. And this is kind of how I was really taught about it in medical school, is that these are the top killers. If you look at cancer and heart disease, they're over 20% each in terms of responsibility for women's health, deaths for women. In terms of what I do when I have women coming in for annual exams, if I say annual exam, what does that make you think of? Pap smear, right. Pap smears there's been an interesting change in the past couple of years with regard to pap smears, which is we have learned that we're probably doing them too often. So the recommendation for how often we should do them has really been rolled back a lot. And what I see happening is that kind of makes more room in the annual visit to talk about these other things that are actually really more important to women's health. Part of the reason that cervical cancer is not up here is that it's included here under cancer, but it causes maybe 0.1% of women's deaths. So in terms of these other things, it's very, very small. Part of the reason for that is that pap smear screening has been so effective in eliminating cervical cancer as the #1 cause of cancer deaths for women like it used to be. But in terms of what we need to do to keep our health rolling forward, the cervix is a teeny tiny part of that. And by revising those guidelines, now we have more space to talk about these other things. I heard a talk by a guy in the past year which really kind of changed my thinking about how to look at these things. His name is David Katz. Anybody heard of him? So he's a preventive medicine physician. He's up at Yale. He wrote a book which is fantastic called Disease Proof: The Remarkable Truth About What Makes Us Well. And I thought about paraphrasing him, but then I thought, why don't I just give him 2 minutes of video and let him speak in his own words. So this is 2 minutes from David Katz about a different way to think about that.
Prior to 1993, when we talked about the leading causes of premature death in our society, the things that take years from life and, more importantly perhaps, life and years, the only correct list of answers was diseases. Heart disease is the #1 killer, cancer is #2, stroke is #3, arguably diabetes is #4. That has been the way of it for decades. Still the way of it. But in 1993, 2 epidemiologists published a paper in the Journal of the American Medical Association entitled Actual Causes of Death in the United States. But Bill Fahey and Mike McGinnis often point out, should have been obvious all along. Diseases are not causes. Diseases are effects. And what we really wanted to know was, what was causing the diseases that were taking years from life and life from years? What was really in the way as we tried to get to the prize of vitality, good quality of life? Well, they crunched the relevant numbers and told us a list of 10 factors which overwhelmingly we control in our daily lives was accountable for virtually all of the premature deaths that occur in our country. And that list of 10, the full extent of which need not concern us today, was in turn overwhelmingly dominated by just the first three. Tobacco use, dietary pattern, physical activity. About 80% of the action was there. Well, 1993 is getting to be an old vintage. We have fresher data. 10 years later, scientists at the CDC reanalyzed this issue and reached exactly the same conclusion. Bad use of feet, forks, and fingers were still the leading causes of premature death in our society. All that had changed over the span of a decade is that the gap between tobacco was number one, and bad diet, lack of physical activity, and combinations number two had narrowed. Partly for a good reason, strides against the use of tobacco. Partly for a bad, deteriorating dietary patterns, less physical activity, worse obesity, worse diabetes. Other voices began to say, maybe there's an opportunity here. If these are the leading causes of premature death, if we turn them around, might they not be the leading causes of renewed vitality?
Mm-hmm. Have you encountered that before, the feet, fingers, forks? No? I hadn't heard it until this year. It's not a new book. But I think it's a great way to think about it. And if you look back at this list here, if you think about inactivity and poor diet, that affects diabetes, probably Alzheimer's, stroke, cancer, heart disease. Many cancers are obesity related. If you think about smoking, it actually hits every single thing on this list, including fires from people falling asleep with a cigarette, and lung disease, even Alzheimer's is associated with smoking. So those three things, so increasing our physical activity, eating a balanced diet of good food, and not smoking, it should kind of be the undercurrent for everything we're thinking about with women's health. And all of that, it's great to have some time to talk about that. I'll go through the different ranges of what the different recommendations for pap smears are, but now it's nice to have some room in the annual visit to try to talk about those things too. So this is Dr. Katz's 10 healthy habits, and I made some half sheets that have these for you. And this is kind of the foundation of habits of healthy living. So just avoiding fast food, drinking water, eating salad and greens, getting some exercise every day, making sleep a priority, avoiding mindless eating, eat foods with identifiable ingredients instead of chemicals, plan all your eating occasions, tell everyone what you're doing, and choose what goes into your mouth. And those 10 habits, if we adopt them, can kind of head us in the right direction. And I'm certainly not perfect on these, but I'm trying. And Dr. Katz would say, don't let perfect stand in the way of what's possible. If health is a journey, what's more important is which direction we're heading in. And sometimes I see patients who from year to year are gaining 2 pounds, 8 pounds, and over the course of several years, they're heading in the wrong direction. And if we adopt some of these habits, they can kind of head us back in the right direction. So using that, let's kind of walk through some different ages of patients that I see and people you might know. So a 16-year-old, most of these are celebrities, and her mom has brought her in to see me. She's never been sexually active, and her mom just kind of wants to get her plugged in with a gynecologist so she knows what that's about. So at this age, this is a patient who's a good candidate for Gardasil vaccination, which it will protect her from cervical dysplasia and cervical cancer in the future. It's been a little bit controversial because some moms are afraid that vaccinating their daughters against cervical cancer will kind of give them permission for risky sexual behavior. And I think of it differently. I think I vaccinated both my little kids for hepatitis B, which is also transmitted through bodily fluids. And they're 5 and they're 8, and neither one of them is using IV drugs yet, which I'm happy with. And it's something that I did for them to help their health. And it's less that this is an age range that is going to go out and have risky sexual behaviors. It's more that this is a point where their body can respond to this virus, and that the virus is a thing that they're almost certain to be exposed to later on in their life. And if this little girl has no sexual activity at all until she gets married in her late 20s, and her husband has ever been sexually active with anyone in the past, she could be exposed to the HPV virus. And now is the time when her body can react to the vaccine in a way that's going to protect her if that happens. In terms of causes of death at this age, accident prevention is really up on the list. So we want to talk about bike helmets and seatbelt safety. She's telling us she hasn't been sexually active yet, and a lot of adolescents tell the truth, not all of them do. So I want to educate her about sexually transmitted diseases. I want to try to help her understand that there are infections she could contract at this point, which could have lifetime implications, could cause tubal scarring and make her have trouble when she's at the point where she's ready for pregnancy, or cause outbreaks that she might be faced with for the rest of her life. I want to talk in advance about contraception. And in the contraceptive world, we've kind of moved away from taking pills every day and moved towards LARC, which is long-acting reversible contraception. The Nexplanon is an implantable rod. Hey, Shan. That we place in the upper arm for a patient. It gives very, very reliable birth control for about 3 years. And that eliminates not just taking a pill every day, but it eliminates going to the pharmacy every month or 3 months, or worrying about at the end of 12 months whether there are refills left. And so we see a lot lower contraceptive failure with that kind of method. The healthy habits that we talked about, they have a place in this age range too. So to get them to see that the fast food is not good nutrition. These patients will all women reach their peak bone density at about age 20. So these are her years for building her bone density with calcium intake. You want to try to get them to drink water. So just not having juice and soda in the house can help steer them in that direction. And then physical activity, kids should really have 60 minutes of physical activity every day. And then does she need a pap smear? Not yet. Age 21 is the youngest age that we start doing paps nowadays. So now we have a newlywed 20-something, and her last pap was 3 years ago. So now we're looking at a little different set of issues. So if she's under 26, she's still in the age range where she could get the Gardasil vaccine. And she's still in the age range where accidents are a leading cause of death. Counseling on STDs, well, it's recommended that anyone who has had a new partner in the past 12 months have STD testing. So for some newlyweds, that might still be the case. So I just want to ask questions to help see if she would benefit from testing or not. And then counseling on family planning. Do they want to get pregnant now? Do they not want to get pregnant now? And how can we help them meet those goals? Again, on long-acting reversible contraception, the Mirena IUD is another very, very effective method. So we place that in the uterus in the office. It's kind of crampy to have it placed. Once it's in, it actually has a lower failure rate for birth control than having a tubal ligation, but it's reversible. When the patient wants, she can have it pulled out, she can rapidly get pregnant again. With it in place, half of women have no period at all, which most patients love, and the other half usually have a very light, not painful period. So in my opinion, that's just about perfect birth control. There's no maintenance once it's in place. It's very effective, and for most patients, it really changes their menstrual cycle in a very positive way. I neglected to say on the last slide, don't start smoking. Tobacco companies know that if they can get women in their adolescent years and early 20s to start smoking, they have a very high chance of becoming a lifetime smoker. The tobacco companies know that, and we should make sure our girls know that too. Again, she should be working on her healthy dietary intake, working on her calcium, and if she's thinking about getting pregnant in particular, getting towards her ideal body weight. Drinking water, and at this point, physical activity, she should be doing 30 minutes 4 to 5 times a week. And at this point, a pap smear every 3 years. All right, so now we have a 26-year-old who's coming in. She's ready to have a baby. So we want to talk about immunizations, especially pertussis, which we're seeing outbreaks of here in Louisville. Still some accident prevention. Still those same healthy habits, so don't start smoking and quit if you're a smoker prior to trying to get pregnant. In terms of healthy eating, we want her to have a balanced diet still. We want her to start paying attention to her mercury intake and how much fish she eats. We want her to be taking 0.4 milligrams of folic acid every day for at least 3 to 4 months before she starts trying to conceive, because that can prevent neural tube defects. And still the calcium. And again, drinking water and physically active. We would take a look through her medication list and see if there are antidepressants, antihypertensives, any other medications that might not be optimal for pregnancy, and try to switch her over to something that would work for pregnancy. And then I'd talk with her about her menstrual pattern and when she's likely to be fertile. So a lot of patients get to this point and they've been trying for the past 10 or so years as hard as they can not to get pregnant. So reversing that, it takes a little thinking. And the irony of it is, if you've been working very hard at trying not to get pregnant, doesn't mean that the second you stop trying not to get pregnant, you'll get pregnant. So sometimes it still takes a little bit of time. So what I tell patients is that they can start, a lot of patients, to identify the symptoms of their ovulation. So some patients will have a stretchy cervical mucus. Some will feel a little bit of cramping on one side or the other. And if they're right that that's ovulation, then 2 weeks after that day, they should get their period. So if your menstrual cycle is growing and lengthening in terms of number of days between periods, from the start of a period until when you ovulate is the time of the cycle that can grow and shift. But from when you ovulate to when your next period comes really should be predictably 2 weeks. And the pregnancy test companies will tell you that their tests will turn positive before you've missed a period, but that's not actually true. It kind of helps them sell more pregnancy tests. So I tell patients, if you're able to pick up when you're ovulating, then count 2 weeks out from that day, and then on that day, with the first morning void, because that has the strongest concentration of the pregnancy hormone, then you can do a pregnancy test, and then do it every other day or so until it turns positive or until your period comes. And at this point, she's still 26, so we continue to do a pap smear every 3 years. And now she's pregnant, which is fantastic. So when I moved to Louisville, I told my real estate agent that I was going to come deliver babies at University Hospital, and she said she didn't know that we did that here. And I find that that's true in Louisville. A lot of people don't think that way about University Hospital. So I have a brief word from our sponsor about the excellent obstetrics we're providing upstairs. These are some data showing that in the city of Louisville, we have the lowest cesarean section rate, which we're proud of. I think in part that comes from the fact that we always have an in-house attending upstairs on labor and delivery. So if I'm on call and I'm getting impatient and thinking somebody should have delivered an hour ago, if I throw in the towel and do a cesarean section, that does not mean I get to leave and go home and have dinner with my family. I'm still here for the duration of my shift. So I think that lets us be a little bit more focused on what's important for the patient rather than what's important for our own schedules. And then this is our success rates with vaginal birth after C-section. So UK and UofL, you can see we're both really high. And again, I think that's also because we have 24-hour in-house attending coverage, which is something that you need to offer trials of labor after cesarean section to your patients. That's one of the Healthy People 2020 goals, is to get to 18.3%, and we've already exceeded that here at UofL. So that's good. We also have a great focus on breastfeeding support. We do skin-to-skin care with the baby after delivery. We have a lactation consulting team. We've been increasing our rates of breastfeeding on initiation and exclusive breastfeeding, and then we're on the path to become the second baby-friendly hospital in Kentucky. So be proud of working here. This is a good place. All right, moving onward. Now we have a 33-year-old. She's had a tubal ligation. She had a normal pap with negative HPV typing last year, and her BMI is 37. So she's no longer interested in contraception. She's got her method in place. Her family's complete. I think what's really important at this visit is to try to get somebody focused on this being the first day of the rest of their life and starting to go in the right direction on that pattern of healthy habits. As I said before, we don't want to let perfect get in the way of what's possible. And she is probably not going to be able to go to the gym 4 to 5 times a week. I can't. But how can she adopt smaller changes, smaller healthy habits that will head her in the right direction? A couple of tools that I find very, very useful are a calorie tracking app like Lose It and MyFitnessPal. So these are pretty easy. You can put them on your smartphone. They're either free or a couple of bucks. And for a week, you can chart everything that you eat and drink. And I've had patients tell me some things like, wow, I never knew how many calories I was taking in sweet tea. Or I thought almonds were a healthy snack, but it turned out I was eating 6 times the amount that you're supposed to eat. And that was a big calorie pitfall for me. So it's not a great plan. It's very labor intensive to plan on doing it for the next several years, but to do it as a snapshot, just to decide for the next week, I'm not traveling and I'm doing my usual routine. where does my usual routine fit in terms of how many calories I should be eating every day? It's a great way to do it. And then a pedometer. So there's a lot of evidence that if you can get over 10,000 steps in your daily life, that starts to have health benefits. So for someone who can't make it to the gym, they can get a pedometer. They can, when they leave the office, walk twice around the building and park far out in the parking lot instead of as close as possible, and take the stairs instead of the elevator. And slowly, that can head you in the right direction instead of continuing in the wrong direction. So those are two very practical tools that I find helpful. All right, moving on. 40-year-old, never pregnant, no abnormal paps, and had a pap smear last year. And her sister died of breast cancer. So now, in addition to the other things that we've been talking about all along, we're going to take a look at family history again. Sometimes when you're younger, you haven't had very many folks in your older generation pass away or get sick yet. So you might think of yourself as somebody who doesn't have a strong family history for cancer. And then you come to a moment where you kind of have to take a pause and look at that freshly and realize, wow, actually in the past 10 years, I've had several different folks who are now diagnosed with cancer. In terms of breast cancer screening, there's a couple of different ways to approach this. There are different bodies that have made different recommendations. The American College of OBGYN and the American Cancer Society are recommending that we have a discussion with our patients, and that they prefer an annual mammogram starting at age 40. And I would expect that somebody who had lost a sister to breast cancer would probably want to take that tack with her screening. She should also be having a pap smear now every 5 years with HPV typing. So over 30, that's the recommendation for pap smear screening, is every 5 years with an HPV test. And at 40, if she hasn't been pregnant, I want to talk with her about that and let her know she's still got a little bit of time, but she needs to head in that direction quickly if she does want to have a kid. And then I start to talk a little bit about anticipatory guidance on menopause. So how old her mother was when she went through menopause, and different patterns of bleeding that some patients have as they head into that time. And now we have a patient who's sort of similar situation. She's on the go and she's a minimalist regarding healthcare. So she, I think, might want to go a different route with her breast cancer screening. The U.S. Preventative Services Task Force a couple of years recommended that we actually switch to every other year mammograms after age 50. And by following that recommendation, it's about 80% as good at catching a cancer. Some patients are satisfied with that, some are not. It saves an awful lot of money on a population basis, because we have fewer patients that we end up calling back for repeat views or having biopsies of things that ultimately prove to be benign. So this is what the American College of OBGYN means when they say we need to have a discussion with our patient and see what her feelings are, her family history, her approach to risk. And a patient like this might very well tell me, I don't want to bother with it, I'm good, I'll do every other year after age 50. And that's okay. So now we have this 50-year-old who's no abnormal paps or mammograms, but she does want every screening that could be indicated because she spent a lot of time with people with a lot of different health problems. And actually, I'm not talking here about lipid screening and thyroid screening, so I'm kind of talking about the imaging studies that are usually recommended. So again, that basis of those healthy habits. Breast cancer screening, so I'd review the different options with her. She should still be having a PAP every 5 years with the HPV testing. And now she's eligible for colonoscopy also, so that should be the first at age 50, and then we look to the GI folks to tell us how often to repeat it after that. If it's completely clean, they might tell you come back in 10 years. If they see a polyp, they might say 3 or 5 years, but the first study at age 50. And then again, talking about anticipatory guidance for menopause. So the average age for menopause is 51 or 52, and it tends to follow what your mother did. So it's helpful to know what your mother did. And now this patient, she's 53, normal mammogram 8 years ago, no colonoscopy ever, no PAP for 10 years, and she's finally coming into the doctor because she's having major hot flashes. Any thoughts? I mean, she looks like she has her act together, right? She's Diane Keaton. Any thoughts why she might have not gotten any of these things done? Yeah, that's possible. That's possible. It's also possible that she's been a primary caregiver for somebody else. And one thing that we know is true for women's health is that when you are taking care of an older family member, women tend to put their own health on the back burner. We see that. So if you're in that role, you need to kind of articulate that. Let that be in your consciousness, that this is something that's known about women who are taking care of somebody. And don't let perfect get in the way of possible. Don't just let it go maybe that you're gonna, in a month, catch up on everything that you need to do. But pick something quarterly, once a season, that you're gonna do to try to kind of stay on track with your health. So breast cancer screening, PAP every 5 years with HPV testing, colonoscopy, we'll kind of get her all plugged in with that. And then counseling on hormone replacement therapy. So there's been a lot of press in the past 10 years about the risks of hormone replacement therapy. We used to think of it as sort of a vitamin that once the ovaries shut down, we needed to continue to replace for the life of the patient. And now we know it's not exactly true. It's not true. We don't think of it like that anymore at all. It has risks. So there are excess risks of stroke and breast cancer. I think it's important to think about the magnitude of those risks. And all of those things, a handful of women out of about 10,000. So for a patient who comes in, she's having a hot flash once a week, but she just rolls over and goes back to sleep, probably she doesn't want to take that risk. For somebody who comes in to tell me, they're coming into the doctor for the first time in 10 years because these hot flashes are driving them so nuts, and they're up several times a night, and they feel irritable all the next day, and it's interfering with their work success and their relationship, that patient is probably very willing to take a risk of a couple out of 10,000 of a stroke that she might not have had to try to get her quality of life back to what it was before. And we think now that the right thing to do is to use these medicines to try to control those symptoms for a couple of years and then wean them down as the patient tolerates it. So that's what I would talk to her about, starting on hormone replacement therapy with a plan to continue it for 3 or 4 years and then weaning it down after that. All right, I love this lady. She's 80 years old. The part about the hysterectomy I made up, they didn't reveal that on the news. Hysterectomy for bleeding at age 40, normal mammogram and colonoscopy before her skydive this year. She hasn't had her bone density tested. She's finding sex uncomfortable. And this says, if you can't read it, woman survives skydiving mishap on 80th birthday. I mean, just look at her. So when I see a patient like this coming into the hospital, it reminds me of a time when I sat next to my Uncle Frank at Christmas dinner, and he was telling me stories about fighting in World War II. And it was amazing, and he ate an entire stick of butter while he was telling me these stories. He's in his 90s, so I'm watching him eat this butter, and I'm thinking, who am I to tell him what diet he should be eating? He's 90 years old. Obviously, this has worked so far. So I would talk with her. Her breast cancer screening is up to date. Her colonoscopy is up to date. In terms of finding sex uncomfortable at this point, a little bit of vaginal estrogen can completely reverse that for patients. And this is one of the problems, atrophic vaginitis, that starts to happen as estrogen levels fall after menopause. I love finding that problem because it's so treatable and so life-changing. And I know if I give a patient a little dab of estrogen, in 2 or 3 weeks, she'll come back to me and life will be completely and totally different. So I would talk to her about that. And in terms of bone density screening, usually we start that at about 65, unless patients have had risk factors in their lives like smoking, family history of osteoporosis, a personal history of a fracture or a lot of steroid use, or if they're very slight, if they're one of these little teeny tiny women. I think this lady would probably tell me that she drinks water and that she stopped smoking when she was 30. And she stopped tracking her calories decades ago because she knows she's eating what's okay and it works for her. She eats a balanced diet. I bet she walks every day. I bet she doesn't drink very much. She doesn't drink a lot of coffee. And all of those are probably why she's still walking around after her skydiving incident. And I think she probably laid a lot of foundation in terms of healthy habits in her life. And I think probably this is what I want to be. I want to go skydiving when I'm 80. And what will head us in that direction is kind of that foundation of healthy habits that build up over trying to live that way, not perfectly, but trying to live that way over the course of our decades. And I have to say, I love it on a good day. On a good day, I came home from the office and I've seen most of these women, and I've gotten to spend some time with them, gotten to hear what's going on in their lives. And that's a fantastic part for me of what I like about my job. So here's to good women. May we know them, may we be them, may we raise them. All right, thank you all for coming.